Good morning. Thank you for attending the session. This track is going to be focusing on respiratory failure with various topics that we still find mystery and we need more information in. The first speaker is Prof. Arthur Slutsky. It's my pleasure to introduce him. He doesn't need to be really introduced. He's a professor of medicine and surgery and biomedical engineering, and his main interest is translational research focusing on some mysteries that we still have in critical care, like atelectotrauma, biotrauma, and ventilator-induced fibrosis. His talk is going to be about the history of mechanical ventilation from Vesalius to villi. Welcome, Prof. Slutsky.
Thank you very much. It's a pleasure to be here. And as I said in my first talk, I've really enjoyed this meeting. It's been a fantastic meeting. Congratulations to the organizers. Really, you outdid yourselves. You did Kuwait very proud. And the people have been incredibly nice and hospitable. So I've tremendously enjoyed myself. So thank you very much. So, really. So the talk is mechanical ventilation from Vesalius to villi. Actually, it's going to be, I'm going to start a little earlier than Vesalius, as you'll see. In terms of conflicts of interest, there's no real relevant conflicts for this talk on the history. I've divided this into sort of three sections. The first is, I'll call it the physiologically naive period, and you'll see why that's the case, as you can imagine. And this starts actually back with Aristotle and with Galen. They were both as very famous physicians, philosophers, and they were one of the things that they were interested in was, why did people breathe? Because, you know, back then, of course, no one knew about oxygen, carbon dioxide. So it was thought, they both thought that the breathing was required to move the blood, that it hasn't to do with anything, any air coming in, but it's really the movement that caused the blood to move. Galen, in particular, really had a huge impact for the next millennium, really. So his work, he was an anatomist. He did anatomy on animals, not on humans. And after Galen, from about I would say from the 2nd to the 15th century, were considered the Dark Ages. And they were the Dark Ages. We think now about how things change. You think, you know, from one day to the next, there's AI, things change within 24 hours or less. Back then, nothing changed. So if you lived a certain way in the year 300 or 400 or 500, six centuries later, you lived the same way. So nothing much changed. But then there were some advances a little later on. One of the first was Ibn Sina, actually a Muslim who was a leader in medicine at the time. He was also a philosopher and did some amazing work, actually. He wrote a number of books. One was called The Canon of Medicine, and apparently this book was used in the sort of in the Middle East and the Gulf states. Weren't they Gulf states, of course, back then, but was also used in Europe, and was translated into Latin and was used for 5 or 6 centuries. So a really remarkable individual, probably the most important physician of that time of the Middle Ages. We'll now move on to Vesalius. Vesalius was a professor of anatomy in Padua at a young age, at 23. He actually started to dissect human cadavers and completely contradicted a lot of the anatomy that Galen had undertaken. And this put him in conflict with the church, as you can imagine. And in 1555, he wrote a really remarkable book called De Humani Corporis Fabrica. And some great pictures here. He was the premier anatomist, probably again of the Middle Ages. And in this book, there's a section, I don't know if you can see here, it's not very clear, but there's a pig who's lying on a bed, essentially, and he's got something in his neck, and it turns out to be, well, I'll read it to you. It said, "But that life may be restored to the animal, an opening must be attempted in the trunk of the trachea, into which a tube of reed or cane should be put." Sounds like an endotracheal tube to me. This was quite a few years ago. You will then blow into this so that the lung may rise again and take air. Well, you know, he was doing back then what we do now, so really ahead of his time. Again, nothing much changed over the years, over a century. And then Robert Hooke was a famous individual in the UK. He was I would call it a polymath, incredibly brilliant individual who was multi-talented. He did cell biology. In fact, he was the first person to coin the term cell. He was an astronomer. He was an architect. And in his spare time, he was the curator of the Royal Society in the UK. And as a curator, he had to do experiments or shows for the fellows of the Royal Society every couple of weeks. And one of the experiments, in this one here, of an experiment made by Mr. Hooke, preserving animals alive by blowing through their lungs with bellows, he did a really interesting experiment. And he wanted to prove or disprove the hypothesis of Galen. So this was a picture I had drawn up. Essentially what he did was he had tubes put into the chest wall of dogs, into the lung, and then he had some bellows at the airway opening. And he would blow into the bellows, that would blow gas, the gas would enter the trachea, enter the lungs, and then leave unidirectionally. So it was a unidirectional flow, so there wasn't cyclic movement. And what he found was, and again I'll read it to you, this being continued for a pretty while, the dog lay still as before, his eyes being all the time very quick and the heart beating very regularly. So when there was flow going in from the bellows, the animal was alive. But upon ceasing this blast and suffering the lungs to fall and lie still, the dog would immediately fall into dying convulsive fits. But he soon revived again by renewing the fullness of the lungs. So I think, this was a beautiful experiment that disproved Galen's hypothesis, because there was unidirectional flow, and when there was gas flowing through, the animal was alive. When they stopped the gas flow, the animal looked like it was going to die. So clearly showed that this approach of the movement of the lung, ventilation is required for circulation was not exactly correct. Now, this was some brilliant work by these individuals back then, but really, again, because maybe there wasn't Google, there wasn't a way to transfer knowledge, things were very different. And so over the 17th and 18th centuries, the approaches to resuscitation included strong stimulation. It was thought that that would revive patients. Again, it's very important when you have a hypothesis, that's how you decide on what treatment. The hypothesis was that individuals who had what we call a cardiac arrest or weren't breathing, the reason they weren't breathing was they didn't have enough stimulation. So if that's the hypothesis, then it makes sense to stimulate them. So that's what people did. How did they stimulate them? They would try rolling them over barrels. They would throw their abdomens across a trotting horse. Flagellation, they would beat patients. The inversion method, I guess this is similar to the prone position, so maybe we're sort of doing a little bit of this now. The bellows method, of course, this made sense, and I already discussed this very briefly. And the Russian method, which I think actually could have been called the Canadian method, and that's taking the patient and covering them in ice. And that was supposed to revive the patients. I don't think there were any RCTs on any of these approaches, probably none, except maybe the bellows would be a little bit successful. So let me switch gears now and talk about the second stage, what I call technology advances, and you'll see why. So this was now, we're getting into the 1800s. Oxygen and carbon dioxide have now been discovered. It's thought that oxygen was important for combustion, so therefore for ventilation. Like people didn't understand exactly the mechanisms. They realized oxygen was important. So here's, I want to give you a couple of patents. This was one of the first body enclosing devices. You can think of it as an iron lung, but the patient was sitting. Developed by Alfred Jones and patented in 1864. You can see the patient sat in the box, and there was a seal around the neck, and there was a plunger. And you can see the plunger would go down and up, and that would cause changes in pressure inside the box, which would cause changes in pressure in the lung. Increased pressure in the box would cause exhalation, of course. But this patent was interesting. This device was interesting because what Jones suggested was that this ventilator could cure paralysis, neuralgia, seminal weakness, asthma, bronchitis, and dyspepsia. Also deafness. And when judiciously applied, many other diseases may be cured. Again, clearly, no one did an RCT to confirm any of these. The next is one of the first iron lungs. This was patented and developed by Alfred Wallet in Paris. And his concept was he wanted to have these ventilators along the Seine River, so when people drowned, they would be taken out, put into the ventilator, and ventilated. And again, you can see that the concept makes sense in terms of underlying physiology. Someone would be pressing on the bellows. It would cause air to increase the pressure in the lung, move gas in and out of the patient. An interesting part of this ventilator was this rod, which was on top of the chest, and it was really a way to measure or estimate tidal volume, because as the gas moved in and out, this rod would move up and down. The problem with this ventilator, of course, is that it's very difficult to nurse the patient. How do you get in to take care of the patient? So Peter Lord, who was an engineer, came up with an interesting idea. It's an engineering approach, and that was a concept of a ventilation room. You can see the patient down here, connected with a manifold outside the room, and inside you can see these huge bellows which would push down, increase pressure in the lung, and again move gas in and out of the lung. You can see there was a door, so the nursing staff and the physicians could come in and they could take care of the patient. It would be much easier to take care of the patient than in an iron lung. Now, this was a ventilator that could work. The trouble, of course, this ventilator is very expensive, right? You've got a huge room with big bellows to ventilate the patients. So this one was developed by an engineer. I think some hospital administrator developed the other one, this ventilator. This is the same ventilator using this one room, but now multiple patients ventilated. And as you can see, again, there's a door here for the staff to enter and take care of the patient. And you can see that these are kids. So this ventilator was actually built in Boston Children's Hospital back during the polio epidemic, and I'll come back to the polio epidemic in a few minutes. And here are some pictures taken, what this actually looked like. You can see nurses, these are patients with polio. You can see they're taking care of them on the outside. And then on the inside, you can see that nursing could be done. So I don't know how often, if this was used for very long, but was probably used a little bit based on these pictures. And the final ventilator like this I'm going to show you was one that was developed by William Schlag of Germany. It's called the pneumatic chamber. You can see here, again, physiologically it makes sense because you change the pressure in this box by moving this back and forth. And you can see that the patient would have to do this themselves. I guess this would be like self-inflicted lung injury, the mechanical ventilation. I don't really understand the concept here. Is the person going to stand there for hours and hours and move this? But anyway, this was developed in the 1920s. So these were all ventilators around the turn of the 20th century which were used. Now, I would say the modern era of mechanical ventilation started in the 1950s during the polio epidemic. And what happened was, in 1951, there was an international meeting in Copenhagen on polio. And about 1,500 physicians who took care of polio patients all came to Copenhagen to meet in a meeting like this. And of course, what probably happened is many of them had the virus with them. And afterwards, the following summer, there was a terrible polio epidemic in Copenhagen. And here is just some of the numbers. This is from the paper in The Lancet. You can see the x-axis is time. Here's the number of weekly admissions. You can see it peaked at about 320 admissions in 1 week of polio. And there was a fair number of cases of paralytic polio as well as non-paralytic polio. The problem, of course, is with paralytic polio, mortality was extremely high. Mortality was greater than 80% for these patients. Part of the reason the physicians didn't really know why the patients were dying. They thought at first that it was kidney failure. The patients developed they couldn't measure carbon dioxide levels, but they measured high bicarb, and they thought this was renal failure. And they thought patients maybe were dying because of the renal failure. And Bjorg Ibsen entered the scene at that time. He was an anesthesiologist. He trained at the Mass General Hospital in Boston. Came back a little before this polio epidemic, and he had studied carbon dioxide at the Mass General Hospital. He understood mechanics, and he thought, well, these patients are not dying from renal failure. They're dying of respiratory failure. And in fact, once again, it depends. If you know that, if you have your hypothesis as to what's causing the problem, you can then treat it. And he decided to use mechanical ventilation. And in fact, really, what you'll see, it wasn't really mechanical ventilation, but he put a tube into patients, and then he ventilated them. And you can see from the time that this ventilation was started in these patients, mortality dropped from about 85% to about 45%. A dramatic drop just within 1 month. And this was interesting because they didn't have any ventilators at the time. Most of the patients were hand-bagged by medical students. And there were teams of doctors who provided manual ventilation 24 hours a day, 7 days a week. They estimated that about 1,500 students provided ventilation for 165,000 hours, really quite dramatic. And because patients who were ventilated like this had common problems, they were moved to a single ward. At first, they were all over the hospital, moved to a single ward. And this was really the start of intensive care, because this was the first intensive care unit in Copenhagen. You can see the little circle there where it's thought to be. This was the first ICU in the world in 1952. And this led to scenes like this. This was now negative pressure ventilation, of course. So let's move on now to the last section, and that's what I call from 1970 to the present, and that's the physiology or iatrogenous philosophy, change in philosophy, and randomized control trials. So we've moved away. There's now devices that are much better. The techniques are better. The ventilators are better. And we realized soon afterwards, in fact, during the polio epidemic, we realized that there are complications of ventilation. And there's many complications of mechanical ventilation. Complications related to intubation, sedation and paralysis. A big focus, certainly in the 1970s, was oxygen toxicity, impaired host defense due to the endotracheal tube, auto-PEEP and hemodynamic compromise, and of course, ventilator-induced lung injury. Let's focus briefly on ventilator-induced lung injury. I'm just going to show you one slide. This is taken from a sort of a short editorial that we wrote. And you can think about how we've learned things. If you look at the 1950s, 1960s, the focus then was on barotrauma and air leaks, and there was a lot of work done on that. Then surfactant was discovered, and its impact on certainly infant respiratory distress syndrome. We then discovered volutrauma in the 1970s and 80s, and you can see on the bottom part of this slide is the clinical or the bedside, if you like, this early ICUs, respirator, lung, surfactant trials. And then more recently, in the 1990s, the concept of biotrauma, systemic inflammation, and the fact that biotrauma in the lung could lead to end organ dysfunction and then to death in these patients. Now, this looks like it's relatively new over the past, few decades, but I'd like to go back into the past a little bit as well. I'm going to tell you a story from the Philosophical Transactions of the Royal Society of Medicine from 1744. So it's almost 300 years ago. And it's called Observations of a Case of Recovering a Man Dead in Appearance. So remember, this is almost 300 years ago. And the case was like this. This was Tosek, who was a surgeon, came upon a man who had suffocated because of fumes from a coal pit. So apparently the patient was lying on the ground, not breathing, apparently pulseless. And what he did was, there was a big question back then of whether you use mouth-to-mouth resuscitation or other approaches. He used mouth-to-mouth resuscitation. And he said he applied his mouth close to the patient's, and by blowing strongly, raised his chest fully. He immediately felt 6 or 7 quick beats of the heart. In 1 hour, the patient began to come to himself. Within 4 hours, he walked home, and in as many days returned to work. So pretty good resuscitation, I'd say, right? But so why am I talking about this now? Why did I present this case? Well, in the discussion of this paper, what he wrote was, some had suggested a bellows, but blowing would be preferable. So some people, for a patient like this, had suggested use this bellows, but he thought a mouth-to-mouth would be better, as the lungs of one man may bear, without injury, as great a force as those of another man, which by the bellows cannot always be determined. I mean, this is ventilator-induced lung injury. Like, this is back 300 years ago, really understood that if you put too much gas in the lung or too high a pressure, you're going to cause injury. So anyway, all of this led over time to a change in philosophy of mechanical ventilation. And I showed a couple slides a couple days ago. The change in philosophy was, if you think about the 1960s to the 1990s, the focus was on getting normal blood gases. And I showed a slide a couple days ago in the meeting from Roger Bone. He had an abstract in 1975. And it's an abstract in which many patients with ARDS developed bariatrial trauma, had chest tubes in, and he looked at the tidal volume used. Tidal volume was, in the patients with bariatrial trauma, was 23 mLs per kilogram measured body weight. 23. That's 4 times what we use now. So of course they developed, and the reason was you wanted to get normal blood gases. Now, of course, the focus on lung protection. And normal blood gases are less important if clearly you want a patient to be oxygenated. And over the past number of years, there have been a number of randomized controlled trials addressing the iatrogenesis of mechanical ventilation, starting from a nice paper by Laurent Bouchard on non-invasive ventilation. Others.
2 minutes.
Perfect. Thank you. The prone position, studies on prone position, neuromuscular blockers, prone position again, high flow oxygen, and extracorporeal membrane oxygenation. Now, these have changed practice dramatically. So in conclusion then, there's been a clearly increased understanding of pulmonary physiology over the last couple of millennium, of course. I think the focus now is on minimizing iatrogenic consequences of mechanical ventilation. This has led to a change in philosophy, and we all use lung protective ventilation. We don't worry so much about the PCO2. And there's a lot of randomized controlled trials that have provided more definitive evidence of efficacy. But clearly, there's a lot to learn from the past, as I showed you when ventilator-induced lung injury was really understood to some extent 300 years ago. So thank you very much. Thanks for your attention.
Thank you, Dr. Slutsky, for the great presentation. It gives me great pleasure to introduce our second speaker, Dr. Martin Erner. Dr. Martin Erner is an assistant professor in the Interdepartmental Division of Critical Care Medicine and the Department of Anesthesiology and Pain Medicine at the University of Toronto. And he's staff intensivist at the Toronto General Hospital. He graduated from the University of Zurich Medical School and completed his specialty training in anesthesiology and critical care medicine in Switzerland. His research focuses on mechanical ventilation and extracorporeal life support using advanced methods for casual interference and large observational data. And he will speak to us today about the factors modifying the effectiveness of ECLS in acute respiratory failure. Dr. Martin.
Thank you so much for giving me the opportunity to present recent work from our group. I do not have a conflict of interest to disclose with regard to this topic, but I would like to disclose that it's the work of a team, Eddie Fan, Conview, Mireille Schnitzer, Phoebe McCauley, and the Toronto Intensive Care Observation Registry, and of course the Interdepartmental Division of Critical Care Medicine. So before we can talk about factors modifying the effectiveness of ECMO therapy, we need to briefly talk about how we actually know, or what is the current knowledge about effectiveness of ECMO therapy. And the biggest and most famous trial is the Aeolian trial, which compared ECMO therapy if the PF ratio, in patients with a PF ratio of less than 80 millimeters of mercury versus conventional mechanical ventilation. And this trial illustrates how difficult it is to conduct critical care trials. First of all, it took about 6 to 7 years to recruit these patients. Practice might have changed over the time period of 6 to 7 years. Also, 16% of screened patients were already receiving VV ECMO treatment, so their selection and maybe PROMs with generalizability. Then there was a crossover of about 30% of patients from the control group to the intervention group, which illustrates that you can have significant selection bias in the analysis of an RCT if you have non-adherence during follow-up. And finally, different analyses of the same data led to different conclusions. You see the original conclusion here in the New England Journal of Medicine, early application of ECMO was not associated with mortality at 60 days. That was significantly lower than that in the control group. And then Ewan Golliger and colleagues did a reanalysis, a Bayesian reanalysis, using another statistical framework in JAMA, and they concluded the posterior probability of any mortality benefit with early ECMO is high, ranging between 88 to 99%. And so in a first attempt, in order to see how effectiveness of ECMO therapy could be modified, we tried to replicate the Aeolia trial using data from the Toronto Intensive Care Observational Registry, ICOR, which is data from 9 University of Toronto affiliated intensive care units, academic centers, and we included all patients that were mechanically ventilated with a PF ratio of less or equal than 150 within the first 24 hours of ICU admission, and they could not be on ECMO at the time point where we determined eligibility. We compared usual care plus ECMO if the PF ratio dropped below 80 versus usual care without ECMO. And in these first preliminary, very preliminary data, we looked at ICU mortality up to 30 days and used Bayesian marginal structural models to investigate the per protocol effect in this emulated trial. So what are Bayesian marginal structural models? So what we basically do, the idea behind that is that we take this registry data and we assume that it's data from a hypothetical randomized controlled trial. But neither the clinicians nor the patients were aware that they participated in this trial. So the data is basically data from a trial with really, really poor adherence to the treatment strategies. And we did a per protocol analysis in order to deal with non-adherence to this, to the treatment strategies. In a first step, we created clones. Oh, somewhere over there. We created clones for each patient. So we created clone copies of each patient and assigned one of the clones to the ECMO therapy treatment arm and the other clone to the conventional mechanical ventilation treatment plan. And that is very convenient because patients can contribute to both treatment strategies and provide data for the analysis. It's statistically very efficient, but clones are also identical at baseline. So there is guaranteed exchangeability in terms of their risk of experiencing the outcome. In a second step, we followed these patients over time. And illustrated here, you see that they were not aware that they were in this hypothetical trial. So some of them were adherent and some of them were non-adherent. You see that for patient number 2, the clone that was assigned to the ECMO treatment arm was perfectly adherent, received ECMO, and then unfortunately later died. But if the same clone was followed under the treatment strategy conventional mechanical ventilation, there was a protocol violation because ECMO had been initiated, so we needed to artificially censor this patient and remove the patient from the analysis and only take data from the first 3 days. It's crystal clear that removing patients because they received ECMO will introduce selection bias in the analysis. And we somehow need to adjust for this selection bias, and we did that using inverse probability weighting, and we basically computed the daily probability of remaining adherent to the initially assigned treatment strategy and computed the weight as 1 divided by this cumulative daily probability of remaining adherent. And the reason why we use Bayesian framework for that is The Toronto Intensive Care Observation Registry comprises about 770 ECMO patients. However, if you exclude all the patients that directly came from the OR, already on ECMO, that were cannulated remotely, that were on VA ECMO and not on VV ECMO, it's a very small group of ECMO patients that we are actually investigating. And the advantage of the Bayesian framework is that the sample size is reflected in the size of the credible interval for the estimates. Bear with me, I will briefly talk about the statistics, and you will probably already think, oh, this is this guy from Toronto doing weird and fancy Bayesian statistics, but we tried to make an R package and provide a code publicly available. We will soon release that to make this technology available for researchers to investigate all different types of questions in critical care. And to see how that works and how easy it is to analyze it, you see here an example of the ICOR dataset. Subject number 4, you see day 0, 1, 2, 3, 4, and 5, the follow-up time, how the PF ratio changes over time. And you also see that the patient unfortunately died on day 5 of follow-up, and because the patient died, he could not be discharged from ICU, so the competing event at time point 5 is not assigned. Then in our code, we defined the target trial protocol like we would define the protocol for a trial in a study protocol. We said we want 200 bootstrap iterations. We defined which is the subject variable in our data set, what is the time variable, what is the outcome variable, how long is the follow-up, what are the variables that we want our hypothetical intervention to apply, and then which variables influence non-adherence during follow-up. And then you define as a list object the different treatment strategies. In this case, it's no ECLS, meaning you're non-adherent if you are being placed on ECMO, and ECMO if the PF ratio drops to less than 80. However, that is a bit more complicated because you can be non-adherent if the PF ratio drops to less than 80 and you are not placed on ECMO, but you can also be non-adherent if you're placed on ECMO with a PF ratio of greater than 80. That would not be according to the protocol and be a protocol violation. And we also did not want to include patients that were on VA ECMO or on hybrid configuration. Then we specify the reference intervention and invoke the function do the target trial and plot the results. And these are the results from the analysis. And we had 3,486 patients who met the inclusion criteria, PF ratio of less than 150 and not on ECMO. And you see that these patients in the overall group were ventilated with an FiO2 of about 70% with a PEEP of 10, which is very similar to what we see in the LungSafe database. You see it's not really high PEEP, it's more moderate, low to moderate PEEP. And you also see that there would have been potentially room for more lung protective mechanical ventilation if you look at the values for arterial pH and PaCO2. In the primary analysis, in the overall group of patients with a PF ratio of less than 150, we found that ECMO therapy was effective, so a risk difference of about 5% with a risk ratio of 0.8. And if we went to the subgroup of patients with a PF ratio of less than 100, you see the risk difference is about 9.9% with a risk ratio of 0.74. And these are effect estimates that are very similar to what we found in the EOLIA trial. And now that we have this functioning target trial emulation model, we can use it to investigate and answer questions that have not been answered by the original trial. And you see for different age distributions, comparing apples to apples means we need to compare what happens if we place a 65-year-old patient on ECMO versus what happens if we do not place 65-year-old patients on ECMO. And the risk ratio here illustrates ECMO is highly effective. However, the results need to be interpreted with caution, because what you also see if you look at the estimated mortality in the table on your right side, of course, the baseline hazard of death is not the same in a 25-year-old than in a 65 or 70-year-old patient. And although ECMO therapy might be effective in these patients, and I also would like to ask you to keep in mind that we investigated 30-day mortality in these patients and not 60, 90, 180 or 1-year mortality in these very first preliminary analyses. The baseline hazard of death ultimately determines the prognosis of these patients, and that should be taken into account before placing these patients on ECMO. And the same for BMI. ECMO, we investigated ECMO for different BMI values, and we also found that ECMO therapy was highly effective even in patients with a higher BMI. You see, except for the patients with a very low BMI, where we do not have sufficient data, you see the credible interval is huge. You see that ECMO therapy is effective when you look at the risk ratio, but likewise, if you look at the different BMI values, the baseline hazard of death also determines the mortality in these patients. Even though ECMO therapy might be very effective in patients with a higher BMI, these patients later go to a long-term acute care facility, and these patients will need rehabilitation, and it's very difficult to do rehabilitation in a patient with a BMI of 55. So although the therapy is effective, it's worth to take these results with a grain of salt. Then in a further analysis, we investigated whether we should initiate ECMO to limit driving pressure. To interpret this analysis, it's very important to keep in mind that the average driving pressure, dynamic driving pressure in this situation, was already high at baseline. So in the overall cohort, you see that the median driving pressure was 15. And when we look at the target trial emulation, we see that there was a dose-dependent reduction in mortality for different thresholds for the initiation of ECMO therapy. So the lower you keep your driving pressure, the better the effect on outcome. When we looked at these risk differences, we were a bit surprised to see, because a risk difference of minus 17% seems very large and almost implausible. So we thought maybe we reached the limitations of our modeling approaches here. I mean, it's a relatively small cohort, it's target trial emulation, it's an observational study. However, if you actually look in the supplement of the Aeolia trial and you look at the subgroup analysis where they initiated ECMO therapy based on criteria number 3, hypercarbic respiratory failure, you see that minus 17% risk reduction is very well in the ballpark of what was found in the Aeolia trial. So maybe it's not that implausible. And the second thing, which is kind of reassuring, that there might be a signal for a beneficial effect of limiting driving pressure, is you see that every decrease in driving pressure by 1 centimeters of water for your threshold translated in approximately 1% reduction in mortality. And this is very similar to previous analyses that were conducted with the parametric G formula, which is a completely different modeling strategy, very different from the way we emulated the target trial here. And in this analysis, including all mechanically ventilated patients in the Toronto intensive care, registry, we compared whether limiting dynamic driving pressure to below or equal 15 centimeters of water was better, the same, or worse than a treatment strategy that was usual care. And we found that the intervention reduced reduced mortality by about 2%. And if you look at the average difference between groups, it's only a difference of about 2 centimeters of water, which is kind of supportive and very similar to the effects we found in our ECMO patients. We did an additional sensitivity analysis using target maximum likelihood estimation, is an other methodology to emulate target trials to see if model misspecification could have influenced our results. And we also found that ECMO therapy was highly effective, similar findings, and we used a strategy where we basically on each day of follow-up compared initiators of ECMO therapy versus non-initiators of ECMO therapy. And then we pooled the results from these 7 randomized controlled trials on each day of follow-up. And the pooled estimate was very similar to a study already published in Intensive Care Medicine, although for COVID patient by Shahzad Shaefi and colleagues. And it increased our confidence that we were not just measuring random noise in the universe. So to conclude, I tried to illustrate that target trial emulation is very challenging, like conducting an RCT, which is also very challenging. There is definitely heterogeneity of treatment effects in ECMO patients. What I demonstrated were exploratory analyses with a very small sample size. And yes, there might be limitations of observational studies, model misspecification, residual confounding, positivity assumption violations. However, we tried to be most rigorous to sensitivity analyses and be cautious with our interpretations. And of course, future research will need to investigate outcomes beyond 30-day time point. Overall, ECMO therapy is effective, but the prognosis is mainly determined by the baseline hazard of death of our patients. So if the patient is already extremely frail, very obese, elderly, you might consider whether this is an ideal candidate for ECMO therapy. And as a second conclusion, ECMO is a treatment strategy to limit driving pressure regardless of the PF ratio. That's maybe a concept that might deserve further investigations. Thank you very much.
Thank you very much, Prof. It's my pleasure to introduce Prof. Yassin Arabi. As a leader in critical care research, his CV doesn't need to be introduced. He's gonna present to us on the interface of NIV and whether it matters or not, focusing on helmet.
Thank you very much, and congratulations for this fantastic conference. I echo everything was said about the organization and the scientific content. Very impressive. I'm going to talk about the interface and whether the helmet has a place in our current practice for non-invasive ventilation. I don't have a real conflict of interest, except I was the PI on the helmet COVID trial that I'm going to describe shortly. So why helmet? I mean, we're using non-invasive ventilation now in our ICUs. It's one of the cornerstone of management in many patients with acute hypoxemic respiratory failure. Typically, this is delivered using face mask. But helmet has potential advantages. And probably the biggest one is the first one, that is prolonged treatment with high positive airway pressure. And I don't know in your ICU, but in my ICU, when you use face mask, many patients will have some leak, so I'm not sure about how much positive pressure, how reliable and consistent the positive pressure. Then we give patient a lot of breaks in between to relieve the pressure from the nose. So yeah, they get recruitment of the lung, then they get de-recruitment, then recruitment, de-recruitment, etc. So the effectiveness of the positive pressure ventilation probably is limited by this factor. There are other potential advantages that helmet has less air leak, better fitting, less skin pressure injury, which was really a big issue during the COVID-19 when patients receive non-invasive ventilation for a long period of time, less eye irritation, and less aerosol generation. And it's been used for a long time now in Italy. And certainly during COVID-19, it was used to increase the capacity to manage acute hypoxemic respiratory failure. This is one of our first patients using helmet, and you could see the X-ray on the left before applying helmet, and on the right, 24 hours later. I just had a patient a few weeks ago, very similar changes of X-ray, patient with influenza. So the amount of recruitment is somewhat similar to what you see with an intubated patient. Good improvement in the recruitment radiographically and by using oxygenation parameters. If we go 5 years back in time, February 2000, cases were accumulating in Italy in very high numbers, and many patients were managed on the wards. And you saw in the news, they start to use helmets widely. Many of them were managed on the wards because essentially there were not enough ICU beds, there were not enough ventilators, so patients were managed with helmets. And as I said, one of the advantages also, at least theoretically, the less aerosol generation. On the right side, this is a simulated study. On the right side, using the face mask, and you see the jet of aerosol that comes during expiration. These are two different helmets, and the amount of aerosolization is much, much lower. So in preparation for the COVID-19 pandemic, we are now in March 2000 in Saudi Arabia. We had a national committee. We got a huge number of ventilators, tried to expand the beds, and we got many helmets because we thought we're going to face probably similar problems what other people are facing. Many cases going to be coming to ICUs that may exceed our capacity. Let me just say a few words about helmet. Helmet is a device that has a hood, has a neck seal here, and it has inspiratory and expiratory connections. It allows access to the patient mouth, so it even can be fed if you're going to give him some liquids through a straw. Using helmet can be used to give CPAP, and here on the left you give continuous flow of gas, oxygen, and air with expiratory valve. Very common in Italy, it's used a lot. But it can be used for to deliver non-invasive ventilation. This is using a ventilator. And here you give a pressure support ventilation using inspiratory and expiratory limb. So one of the important studies in this regard is the study from Chicago by Patel and Dr. Kress. This was a randomized control trial, the pre-COVID era, 2016, where patients randomized to receive helmet versus face mask non-invasive ventilation. And the study was terminated early because it showed that using helmet reduced the need for intubation and reduced mortality. It was very impressive. Small study, not very big, but it showed significant reduction in intubation and mortality. One thing to notice about the study, that the patients in the helmet actually received higher positive pressure. The PEEP received in the helmet was a median of 8. The mask NIV received a median of 5. So in retroscope, whether the difference was related to helmet or to different positive pressure is need to be considered. And as we are preparing for our pandemic, we reviewed this, a systematic review came that looked at different non-invasive oxygenation strategy in acute hypoxemic respiratory failure. And really interesting because it showed that helmet is better than everything. Is better than face mask, better than high flow, better than standard oxygen in intubation and mortality. But the helmet evidence was based on small studies, and some of them are really heterogeneous studies. Helmet is used typically for acute hypoxemic respiratory failure. You should use it for patients who can follow commands. Don't use it for patients with upper airway obstruction. Don't use it for patients who are hemodynamically unstable. That will not be a good thing. Typically, you should not use it for patients with high oxygen, and certainly do not use it for patients who need intubation right away. It's probably not very different from face NIV. Now, to use helmet, we used it mainly as a non-invasive ventilation. We did not use a CPAP, and there are arguments for this and this, but in our ICU, we use it for unheated, low compliance, dual limb breathing circuit, apply a viral filter, and we need to good explanation to the patient, and typically we use earplugs. And typically they don't stay long in the patient's ears, but we use them. And you have to put enough pads under the arm so you avoid pressure, because some patients with applying this for 48 hours or more can get some pressure injury in the axilla. So we use it with either non-invasive machines or a regular IC ventilator, and typically using pressure support. We start with a pressure support of 8 to 10, PEEP of 10 or higher, sometimes much higher. And the key in helmet is to use high flow and very short inspiratory time. And typically when it fails, first question to whether the settings were right. You need to use very high inspiratory rise time. And that's different from face mask. So when we implemented this, we created a poster, how to use it. And again, I think the main focus is very short inspiratory rise time. For Servo I, 0.05 second, and on Burton Bennett is 100% inspiratory rise time. So PEEP usually titrated by increments of 2 to get saturation above 90%. And typically, if it succeeds, you'll see patient oxygenation improve very quickly, and you can lower the FI2 quick. Many patients tolerated, not every patient, many patients tolerate the helmet, and pressure support is titrated to respiratory rate. Our protocol is similar to many other people. Typically, to make it simple, the PEEP plus pressure support should not exceed 30, okay? And one thing, when you use helmet, do not look at the tidal volume on the ventilator. It's completely not useful. So you'll see 2,000 ml. This is not the tidal volume it's getting to the patient. This is the tidal volume in the bag or in the helmet. So it's completely not useful. And if you want to see the ventilation, you need a blood gas. Typically, you need to maintain the helmet for 48 hours or more. And very important to recognize one patient not doing well and get intubated. The one advantage of helmet is it allows patient to talk, allows patient to be fed using straw, using suction yanker. We didn't find that it's very commonly needed because most patients actually were awake and following commands. Some patients will require dexmedetomidine. In our study about that I'm going to mention, it's about 40% required dexmedetomidine during treatment. Humidification is essential, and we created a protocol using bubble humidifier. So as the pandemic started to hit Saudi Arabia and Kuwait as well, in May, June, July 2000, we said, probably you should study this in a randomized control trial. And this really was a pandemic randomized control trial. It was interesting, somewhat difficult to do, but it was with the great will of many, many colleagues from 8 sites in Saudi Arabia and Kuwait. We pulled this trial together. 320 patients were randomized to helmet non-invasive ventilation versus standard respiratory care. So 320 patients were randomized, 320 were analyzed, and 150 received helmet non-invasive ventilation, and 161 received usual respiratory support. So continue what the doctors want to do, whether it's mask non-invasive ventilation or high flow or standard oxygen. We included patients who are suspected or confirmed COVID-19, admitted to adult ICU, and had hypoxemic respiratory failure defined as POF ratio of less than 200 despite supplemental oxygen of 10 liters or more. Patients have to be able to follow commands. And we have a list of exclusion criteria that I'm going to skip. So typical patients in the trials were 59-year-old, really typical of the COVID-19 patients we had. And they were severely hypoxic. So PF ratio median was 60, 70, and 76. So a severely hypoxic group of patients. At the time of enrollment, many of these patients were on high flow or on face mask, NIV, or standard oxygen. So this PF ratio really reflects severe disease. These patients were on some respiratory support at the time of enrollment. So in the trial, patients were randomized to helmet, and we were successful in applying this in almost 96% of the patients randomized to the helmet group. There are a few patients who had short helmet some of them by error in the usual respiratory support, but in the helmet group, 43 hours median use of helmet, so that's really not bad, that's very good, versus 0 hours median in the usual respiratory support. And one thing important to note here, that the level of PEEP in the patients who received helmet was a median of 10, and in the patients in the usual support on face mask was also 10. So really, it's a helmet NIV using PEEP of 10 versus face mask NIV using PEEP of 10. We did not find a difference in mortality, nor we found a difference in intubation rate. They were similar. The oxygenation were not different between the two groups, nor was the CO2. So helmet and usual care, which is predominantly was mask NIV, were similar in this regard. There was no much difference in dyspnea, visual analog scale, or device discomfort. We measured this. We asked patients, what's the level of discomfort from the mask? And they basically was not that different. Now, a couple of slides before I end here. This from a review in critical care clinics we put together about the devices we use for non-invasive respiratory support, high flow, mask NIV, and helmet. For oxygenation, I think helmet probably the most effective, in my opinion. I may be biased, but I think it's probably the most effective one in getting oxygenation. Definitely you get higher positive pressure ventilation with helmet than the mask NIV, and certainly higher than high flow. Easy to apply, high flow probably the easiest, followed by mask NIV. Our RTs would like mask NIV more than helmet. But helmet, if you get used to it, is not that difficult. It's not that difficult. You just have to get the settings right. Easy to monitor, by far high flow is the easiest, followed by mask NIV, and then helmet NIV. Ability to eat and drink, when you have the mask on your face and your mouth, you cannot eat. So, but in the helmet, you can be fed through a straw. In high flow, that's easy. Similar communication, I think high flow and helmet give you better communication than mask. The mucosal irritation patients with the mask NIV probably have a lot of air blowing into their eyes and complain about dryness in the eye. Some helmet patients do also, but less. Claustrophobia can be issue in some patients with the helmet. Skin injury, probably the worst is mask IV, and I don't know about your ICUs, but many elderly people will have skin injury at the bridge of the nose. Pneumothorax, I don't think it's related to the interface itself. It's related to the positive pressure ventilation and the lung injury. And in our study, we did not find difference in helmet, by the way, in helmet versus mask NIV between the two. So, conclusion, helmet is an interface. It's another interface to give NIV. It can be useful in some patients. And it probably what matters more is what the settings you use than the interface per se. but I think for some patients, a helmet can be very beneficial. My last patient I used was an elderly person who has a critical aortic stenosis, come with influenza-related ARDS, and I did not want to intubate him. It's really, valve surface area is 0.5. So we put the helmet, and in 48 hours, it was much better. You could argue he could have done better also with the face mask, but I don't know. He did very well with the helmet, dramatic improvement in the X-ray. So at least I would say helmet is at least as effective as other non-invasive respiratory support. If we talk to my Italian colleagues, they will tell you helmet is the best, which might be the case. I think if you use enough of it, I think you build the experience with helmet. Thank you very much.
Thanks, Dr. Yassin, for the enlightening presentation. Everyone now will go and buy a helmet for their ICU. So that will give me a great pleasure to introduce our last speaker for the session, Mr. Thomas Periano, who is a registered respiratory therapist and educator and consultant. He is also a lecturer for the Department of Anesthesia and Division of Critical Care Medicine at McMaster University. He's spoken to more than 50 conferences and authored research, editorials, and textbook chapters, and is the editor of the Center of Excellence in Mechanical Ventilation blog. He's an editorial board member of the respiratory care, and he had several awards and recognition for his contributions to respiratory care, and he will speak about the ventilator asynchrony, consequences, and management. Mr. Thomas.
Thank you very much again for the opportunity to speak at this very esteemed conference. And let's try to talk about ventilator asynchrony consequences and management in 20 minutes, which is something I probably would need to talk a whole afternoon about, but let's do this. It's not turning. There we go. So these are my disclosures. They have really nothing relevant to this presentation. If we were to put an esophageal catheter in every spontaneous breathing patient, you would see that spontaneous effort, you would see a drop in the esophageal swing, representing changes in pleural pressure. And this graphic right here represents the neural inspiratory time of the patient. Now, when you attach them to the ventilator, of course, the asynchrony has to do with the patient-ventilator interaction. And in this example, the ventilator timing is actually an early cycle. It cycles off before the patient's neurological inspiratory time completes, and they end up with what's called early cycling and some breath stacking. Now, asynchrony or patient-ventilator interaction is not just about the timing, it could also be about the demand. In this example, the patient has a strong effort to breathe. The timing may be okay, however, the level of support is insufficient. This is in volume assist control, and you see this large scooping in the pressure waveform, indicating that the patient's not receiving the tidal volume or the support that they require. Now, when you analyze asynchrony at the bedside, it's important to understand how to detect effort by the patient, which I'll refer to many times in this presentation as PMUS, the muscular pressure from the patient. And every mode of ventilation controls either pressure or volume and flow. So they all fall into this category regardless of the name. The three most common modes of ventilation, of course, are volume assist control, pressure assist control, and pressure support. The latter two are pressure controlled, and of course, volume is volume controlled. Now, the patient effort during inspiration will alter the variable that is not controlled. So if you're controlling pressure and the patient's making effort, you're going to look at the flow. If you're in volume control and the patient's making effort, you're not likely to see changes in the inspiratory flow. You'll see scoops in the inspiratory pressure. However, when the patients transition to exhalation, patient effort during exhalation is the same for all modes because it's supposed to be a passive process. Now, asynchrony can be categorized into two main categorizations. One would be over-assistance, and this would include auto-trigger, delayed cycling, ineffective efforts, reverse triggering, which may also include breath stacking, but it's not required for the definition of reverse triggering, and I'll talk about these in detail. Under-assistance would be flow starvation, early cycling, and double trigger, which is also a form of breath stacking, but in this case, the patient triggers both of the breaths rather than a consequence of reverse triggering. Now with auto trigger, if you have an excessive leak on the ventilator, it's obviously very clear that there is auto cycling because your ventilator is doing this, and your alarms are going off and you're rushing to the room to try to fix this. And on the right, it may be more subtle. This is a patient who actually has a very low drive to breathe, but the ventilator is being cycled by cardiac oscillations. And you can see many fluctuations in pressure and flow. For those waveform nerds, this is actually a auto cycle and reverse triggering in pressure support, which is very rare, but can happen if the ventilator is being cycled not by the patient, or sorry, I should say triggered by the patient. And the way to correct auto cycling due to cardiac oscillations is actually quite simple. You just need to change your sensitivity. Most ventilators nowadays, people default to a flow sensitivity for their patients. If you have auto cycling due to cardiac oscillations, just changing your sensitivity to pressure, you'll notice the respiratory rate immediately starts to reduce. And that is simply because the patient is now triggering every breath instead of their cardiac oscillations. It's important to note that patients that this is highly likely happening, are ones where you have unexplained respiratory alkalosis. You look at the patient, looks very comfortable, asleep in the bed, and they have alkalosis. They're overventilated and you're not sure why. Chances are they have some auto-cycling that's occurring. Now, if you have a large leak compensation is helpful on the ventilator. However, if it's auto-cycling due to other reasons, you should change the trigger. And of course, water in the circuit. If you have swinging water in the circuit, many people have noticed that this can also trigger the ventilator. Now I'll talk about delayed cycling. Delayed cycling is the timing of the ventilator, and there's two different types of conditions that I'm going to describe. One, of course, is when you have someone in a mode like pressure control, for example, and your inspiratory time is longer than the flow that's entering the lungs. This here is a patient effort. This represents PMUS. And you have the passive recoil of the lung, and when there is an inspiratory pause, essentially, this is plateau pressure. And what you're seeing here is the elastic recoil of the chest wall. And in this patient with this is a simulation in a very strong effort, it's just barely reaching zero here. However, there's such a huge passive recoil with the lungs that you see this spike in flow. Now, this over here is a real patient in the ICU, and you can see almost how identical these tracings are, and this is a real patient. Another thing to point out is that there is a large rounding of the inspiratory flow during pressure support or pressure control. Normally, it's a decelerating flow when a patient's passive. When they start to inspire, there's a rounding of the flow, and this is normal. However, if it's excessive, you'll need to look at other measures to determine if it's excessive, something like P0.1, which I'll mention. But as you can see, this is likely passive recoil by the patient. Now, another form of delayed cycling, different than this, is in pressure support ventilation. When you have patients with high compliance or high resistance, like COPD or emphysema patients, the time it takes to cycle off at the default setting of 25%, which most ventilators default at this level, you'll notice a change in curvature of the decelerating flow. So it starts to decelerate, and then it sort of changes and just continues on, and it takes longer to get down there. This is an indication that you have delayed cycling and pressure support. The patient has started the breath here, they've stopped breathing here, they've now entered the passive phase, and it still just has not cycled off. And this is a huge cause of ineffective efforts, which often the expiratory flow is unnoticed by clinicians. So the clinical consequences of delayed cycling simply is the ventilator gives flow and volume beyond the point of the patient's demand, and this excess flow, of course, gives excess volume. You end up with delayed cycling, less expiratory time, less lung emptying, dynamic hyperinflation. You start with having trigger delay and trigger workload, respiratory muscle workload, and non-triggered breaths or ineffective efforts. This is actually one of the main causes of ineffective efforts on patients on the ventilator. And I would tell you that as a respiratory therapist, most respiratory therapists start adjusting the trigger when they see patients can't trigger the ventilator. And the main problem is over-support of these patients. And this was actually studied in 2008 in this study by Arnold Thiel and Laurent Bouchard, where they looked at patients with a high asynchrony index, and this means the total number of missed breaths divided by the total number of actual respiratory rate of the patient, so including the missed breaths. Patients with more than 10% asynchrony, first they tried adjusting PEEP to see if they could correct these ineffective efforts, because some people will also, instead of adjusting the trigger, they'll try to adjust PEEP. They found it was not effective at reducing asynchrony. However, decreasing pressure support was the best way to eliminate this ineffective efforts, followed by changing the timing, which is the cycle off criteria. I have a patient we had in our ICU here receiving a very high level of pressure support of 24, and the respiratory rate on the ventilator is 14. And this was being charted all day by the nursing staff and the respiratory therapy staff. The tidal volume is quite high. It's almost 700 mils. This is more than 10 mils per kilo for this patient. And in between each breath, you can see an ineffective effort. And of course, when you walk into the room and you walk back out and you say you fixed the patient, the nurse looks at the respiratory rate and says, "What do you mean? They're now tachypnic." They feel that you've broke your patient. So it's very important before you correct these things to point out to everyone around you these missed triggers so they're not surprised when the respiratory rate doubles. But now we have a patient with 6 mils per kilo, breathing 25. They still looked comfortable. I was not concerned with this patient at all. In fact, if you want a little pearl of knowledge, if your respiratory rate is below 20 on your patient on pressure support, wean the pressure support, please. No normal patient recovering from critical illness will be breathing less than 20 on pressure support. If they are, you probably have missed triggers that you're just not identifying. So another way I mentioned, you can shorten the cycle criteria. So this is a patient where it's taking too long to cycle off and they have ineffective efforts. Just by shortening the breath, I didn't even touch the pressure support, I just shortened the breath, now they're triggering every breath. Keep in mind, if the rest rate on the monitor is 20, it's now gonna read 40, but the patient's not doing anything different. This is exactly how they've been the entire time. Now, reverse triggering, if you use volume assist control and you use relatively low flows, you'll end up having longer inspiratory times. And sometimes what you may see is essentially the ventilator is triggered by normal mechanisms, meaning a respiratory rate. This is why it's called reverse triggering, because the ventilator delivers the breath first, and then the patient responds with an inspiratory effort. So rather than the patient triggering the ventilator inflates the lungs and the patients respond with a demand, okay? And you'll see a scooping in the pressure waveform. However, if you use faster inspiratory flows, like 50 or 60 liters per minute, and you institute a pause on the ventilator, this is what a normal breath would look like. You have very rapid flows, you have high resistive pressure simply because of the setting of the flow, it's not because the lungs are sicker, and you have this plateau. This is normal. But if the patient is having a reverse triggered effort, you'll notice there's no trigger by the patient, there's no drop in pressure, and you see a loss of that plateau. This becomes very subtle. Most people don't notice this, but what you will notice is you'll see this little blip in the expiratory flow, which is very similar to ineffective efforts and short cycling. But what distinguishes the two is the fact that you see this loss. And so most people will see this and think it's ineffective efforts because they've missed the fact that the plateau pressure has dropped. Now, I will point out in my first slide, I had esophageal pressure. If you have this on your ventilator, this becomes very easy to diagnose. It's when you don't have it, you have to get a little bit clever with how you analyze your waveforms. And finally, in pressure control, because the pressure tries to remain constant, what you're going to see is as the flow decelerates, again, the patient, there's no evidence of them triggering. The flow decelerates, and as the patient inspires, the flow goes back up. So you get this M shape in the flow, and you can see the effort continues on into exhalation, and that's why you see this expiratory flow, this blunting of the peak expiratory flow. Now, how do you fix this, or can we fix it? The very first thing you should do is see if you are ventilating the patient faster than they have their own neural inspiratory drive, and decide whether or not it's sufficient. So what we're doing here is just reducing the respiratory rate. And you can see there's no trigger on the patient. You can see there's a loss of plateau. There's obvious ongoing effort. Now we have breath stacking occurring. Some people may say, oh, this is bad. We need to sedate and paralyze the patient. The answer is no. You just need to try them on pressure support, and this is what happens. Now, I'm not going to pretend that some patients have absolutely no drive when you take away the respiratory rate. Some patients with reverse triggering, if you put them on pressure support, they will go apneic, or they will breathe 8 breaths per minute, which is not sufficient for gas exchange for most of the patients you're finding like this. So in those cases, try to stop sedation if possible. Check if the patient's respiratory drive is sufficient, as I mentioned, try them on pressure support, or simply reduce the rate down to 10 and see what happens. Check if tidal volume is sufficient. Some patients will respond if you're using 6 mils per kilo, and if it's safe to go up to 8 mils per kilo because maybe they don't have ARDS or they have very low driving pressure, you can try 8 mils per kilo. I've seen it completely eliminate reverse triggering in some patients. And if you're transitioning a patient out of sedation and the patient begins to breath stack, then you can try using pressure assist control with an I time of 1 second and reduce the respiratory rate by 25%. Only consider sedation and neuromuscular blocking agents when there is a serious concern related to lung injury. Please, if you don't recognize asynchrony, don't sedate and paralyze your patients. We've had a lot of talks on patient self-inflicted lung injury, so if you're assessing the patient's effort and you are concerned with this is a discussion with the team, but just seeing strange things on your waveform you should not respond with sedation and paralysis. But if you do have worsening ARDS and you see constant breath stacking, this is probably an indication to take control of their breathing. And whether reverse triggering is harmful or beneficial for the diaphragm requires further study, and I'll talk about some of these studies that we have now currently. Now, I mentioned that there is this ongoing inspiratory effort. They take a breath, and there's this little blip in the flow here. Early cycling has a similar little increase in the flow, a decrease in the flow, so an increase towards baseline. The major distinguishing factor is the patient's triggering this breath. That's the main difference. If you're just looking here, you might go, oh, is this reverse triggering? No, because the patient's triggering the breath. You can see a drop in pressure right as it cycles off. This is just early cycling. And this is a pressure support patient. There is an adjustment on the ventilator called an inspiratory cycle percent. How many people would turn the inspiratory cycle percent up? How many would turn the inspiratory cycle percent down? How many don't want to answer my question? You turn it down. The way the inspiratory cycle percent works, it's a percent of peak flow. So this patient actually has it set at 60%, which was way too high for them. So the ventilator's cycling off very quickly or soon, and then you can see they still have ongoing effort. Simply by reducing the inspiratory cycle percent, you can then capture their breath more closely. Now, I mentioned that with reverse triggering, you're not triggering it, but if your effort is strong enough when you have the reverse triggering and the ventilator cycles off, rather than having that strange expiratory flow thing I just showed you, it may cause breath stacking, so it may trigger a second breath. And this is the same with early cycling. The patient's triggering this breath. The effort is strong enough that when it cycles off, there's early cycling, but it results in a double trigger. So we usually refer to this as double cycling because they don't trigger the first breath, and this one we call double triggering, but they're both breath stacking, and that's what's important to understand. If you use volume assist control and you walk into the room and you see this, please change them to a pressure targeted mode. I like using volume assist control when my patients are passive. The minute they start interacting, they need to go on a pressure assisted mode. This is PEEP here. This is inspiration. You can see the flow is increasing. This is supposed to be constant flow, but this ventilator will open the valve if the patient's demand is strong enough. And I can tell you this patient's demand is definitely strong enough. During inspiration, they are pulling so low that they are below PEEP. The ventilator is providing absolutely no support for this patient. And even switching this patient to pressure control, we weren't quite ready for pressure support. They were on 60% PEEP of 12 and getting worse, actually. This I would call under assistance. This looks nice. We have some inspiratory curving of the flow, which means the patient is contributing, and that can be okay to see that rounded flow. But the P0.1 is 6.2, which is quite high for this patient. It had been high for days, and we ended up sedating, paralyzing, and proning this patient. They actually did improve quite well, and they did survive ICU. I followed this patient quite closely. Now, the reason why we didn't give more pressure control is because we tried to give more pressure control to see if we could reduce the patient's drive, and in some patients, support just does not decrease their drive. And what happened is they were getting already 9.7 mils per kilo of predicted body weight. If we went up to 10, it was over 12 mils per kilo of predicted body weight. And we didn't want to repeat ARDS-net. Now, the other thing to note is that if a patient is actively exhaling, so they're forcing exhalation, this actually pushes the expiratory flow downwards. So this patient was forcing exhalation, and then they were inspiring, forcing exhalation and expiring. Some patients will do this when they have diaphragm weakness as a way to sort of allow the lung recoil to help them to trigger. Now I'll talk about some of the clinical consequences.
2 minutes?
Last few minutes, yeah, here we go. So one of the things that can happen when you over-support patients with too much pressure support, how many have been called to the room for a patient that is going apneic, and when you show up, they're wide awake looking at you, and you're not sure why they went apneic? And it usually happens overnight when they're sleeping. When you get there, they're not sleeping, so you don't understand. So this is the normal metabolic hyperbola. Basically, it's the reaction with CO2 in a patient's ventilation. So If my patient had a CO2 of 30 and they were awake, the black line is awakeness, they will not go apneic. They will just maintain a low minute ventilation because they don't need to blow off that CO2. Now, if you are asleep, notice this dotted line here, we actually have a period, it's called an apneic or a eucapnic threshold. Like this eucapnic threshold when you sleep becomes an apneic threshold. If you blow off CO2 below that level, the patient will have essential sleep apnea. The reason why when you show up they're awake is because the ventilator alarms woke them up. So some people will say we should use control modes overnight to rest our patients. I personally don't like that approach simply because if you're using that to overventilate them, they're not using their diaphragm all night. Whereas if you wean the support, they can continue to use their diaphragm and then the worry of disuse atrophy is less. So I would wean pressure support and monitor P0.1 to ensure that we're providing effective support. Now I'll quickly talk about asynchrony and risk for the diaphragm, or at least perceived risk. We still need more data. But concentric contraction is normal. When we contract our diaphragms, it shortens, air enters the lungs. During mechanical ventilation, we can have excessive concentric contraction, of course. I showed you the flow starvation. Eccentric contraction is when normally when the lungs empty, the diaphragm is lengthening, and if they are contracting it or trying to maintain some of it, we call that respiratory braking in patients with ARDS. But if they're making a prolonged effort after it cycles off, this is considered or can be an eccentric contraction if they do it during exhalation. But when they do it as a result of early cycling or reverse triggering, we now have this new term that we're calling post-inspiratory loading, because technically they're starting the breath with a concentric contraction, they're ending it with an eccentric, so it's neither one or the other, so we have this new term being thrown around in the literature now. This is an excessive concentric contraction. This is an eccentric contraction. The lungs are emptying and they're contracting the diaphragm. And then reverse triggering and early cycling, this would be the post-inspiratory loading. The data that we have currently, this was published just last year by Coifard and I'm not sure I'm pronouncing the name properly, and Ewing Gallagher. They looked at post-inspiratory loading in looking at reverse triggering and an early cycling. And they found some interesting stuff when they looked at the neuromuscular coupling with using EDI signals. They found that over time, if you spent more time during your day in post-inspiratory loading, the efficiency of the diaphragm decreased over time. However, reverse triggering, we studied this earlier, patients with high levels of reverse triggering, interestingly enough, in the first 24 hours, you were more likely to be off the ventilator or switch to a partial support or a pressure support mode within 24 hours. So just the appearance of reverse triggering, I don't want you to think, oh, this is bad for the diaphragm, we need to stop it. They might be just telling you they're ready to come off the ventilator. They are waking up, they need to be transitioned, and we should try to get them off the ventilator. And finally, this work from Felipe Damiani and colleagues looking at, in an animal model, looking at the effect of reverse triggering, found that if the effort of reverse triggering is mild or moderate, it's actually diaphragm protective, versus if it's high effort, it can have some damage to the diaphragm muscle. So we still don't know. In terms of outcomes, ineffective triggering has been associated with prolonged outcomes by this study by DeWitt and colleagues. However, further data or more recent data says having an asynchrony index of 10% doesn't necessarily mean that it's a bad thing. Again, in this study, they actually had better survival chances if you had asynchrony index. Again, because the patients are telling you they want to come off the ventilator. I'm awake, I'm interacting, do something, please. However, the longer duration of this and the higher power, so if your asynchrony index was like 40 or 50%, that situation was associated with worse outcomes. So what we know and don't know, this is the final little bit here. We know sedating our patients leads to poor outcomes. Asynchronies are associated with poor outcomes or diaphragm dysfunction, but we have not established a true causal effect. Many asynchronies can be corrected through ventilator adjustments. Always choose correcting asynchronies, I should say correcting, rather than treating them with sedation. We are aware of the potential for patients self-inflicted lung injury. We need more studies to determine the best way to mitigate drive and effort. We know that drugs can do it, but can we adjust PEEP better? Can we adjust FiO2 targets better? We currently do not know if the use of sedation or neuromuscular blocking agents is better or worse than the potential consequences of patients' self-inflicted lung injury. So we should be cautious in treating it all with sedation or neuromuscular blocking agents. And I'll just leave you, this is my final slides. If anyone likes to take pictures, this is a summary of all of the asynchronies, consequences, and management. I'll wait till I see most of the phones go down and I'll go to the next one. And please visit my blog and enjoy the free calculator that I have online for you. Thank you.
Thanks very much to all the speakers for the fascinating talks. I just would like to invite all the speakers to the podium for the Q&A. He's not here. He left, actually. No, one speaker left. That's fine. We'll go to the audience if there are any questions. Yeah. Go ahead, sis.
Thank you for the amazing talk. So my question goes to Thomas. I mentioned in your notes and presentation, you said that overnight don't put your patient to sleep or control mode to rest them. So sometimes we do that in the ICU in the morning where we put them in a pressure support to avoid diffuse atrophy, and then we think maybe at night we'll rest them. So they do not have overuse hypertrophy. Do you think there is any data or research that show maybe this is beneficial to rest them overnight, like physiotherapy? They train in the morning, then at night they rest to recover so they're not over fatigued the next morning.
I think we don't know the best answer for that. I know many clinicians will rest patients on night on full ventilation. I don't disagree with that approach. However, I would set a respiratory rate that allows them to be triggering the ventilator. If you do that, you still provide support in the way of you are controlling the inspiratory time. So the patient, when they make an inspiratory effort, it will prolong the breath to the time that you set, and it will allow them to unload some of the work that is required to breathe because they don't need to have a constant contraction. However, when you completely eliminate the patient's drive every night, we have studies. There was a nice study published in New England Journal of Medicine that showed that diaphragm atrophy occurs within 18 hours. So patients hopefully aren't sleeping 18 hours, but the point is that if we have combined every single night of zero diaphragm activity, my concern is that might not be the best approach, but we need data to determine whether that's the best approach. This is maybe a good idea for a study, whether resting overnight on optimal pressure support, optimal meaning allowing the patient to trigger and not over supporting them, is better than complete rest. So I don't have a solid answer to your question, but I do understand that it's a common practice. Some people will recommend it simply because the ventilator alarms won't wake up your patient, so they will get better sleep. So if you don't have a practice of weaning overnight, it might be better to use a control mode simply because the alarms won't wake the patient up. But you can do this with a minimal respiratory rate and allow them to trigger.
Maybe just a follow-up question for that is, does it matter if it's an acute weaning process versus prolonged weaning?
And then, again, another very good question. We really don't have enough data on the proper management of difficult to wean patients. I wish we did. This is always a question when people ask about weaning strategies, right? Should we take them off the ventilator for 30 minutes and put them back on? Like when we do trach mass trials, for example, should we take them off for 30 minutes and slowly, progressively increase the time over days? Or should you just let them go until they fail and put them back on the ventilator? We don't truly have the best approach now. So I think we still need more studies to determine the best approach, whether it's an acute or, I would say in the acute, like the recovery from acute phase before we have difficulty in extubation or liberation, I would allow them to use their diaphragm. Once it gets to that chronic phase, it becomes a very different struggle. And likely nutrition is even more important at that stage.
Yeah, we noticed that when we, these chronic patients, when we let them, on a spontaneous for longer time, and when till they are tired and failed, the next 2-3 days, we can't even keep them 30 minutes. So we suspect that this is fatigue, diaphragmatic fatigue, and then when we rest them for 3-4 days, and then again, we can put them on controlled mode. So actually, I know we have no evidence, but what we do with these chronic patients is that we gradually increase the length of pressure support. So what do you think?
Yeah, and I don't disagree with resting patients who are clearly failing. I think the point, what I was saying about the sleep, is that these aren't patients who were having trouble weaning. These are just standard patients. We've switched them to pressure support, and then the first night on pressure support, they go apneic. So this is happening because we're over-supporting them. When it comes to the difficult weaning, the best strategy is still uncertain, but clearly those patients with severe distress and they just cannot do the work, those patients do need resting. And I'm not, absolutely, please don't take from my lecture not to rest patients. When they're complicated, you do need to rest them. I'm just saying in the standard management, when we switch patients to pressure support, many people, the very first night they're on pressure support, they'll have an apnea spell, and then we just start putting them on control overnight when it may not be necessary. We could just actually wean their support and allow them to breathe. But do monitor the P0.1. I would have had more time. I would have had more time. I would have discussed that as well. But if the P0.1 is very, very low, you can go up slightly. But if it's high, they need intervention. They need more support. Yeah, there's a whole article on my blog on P0.1 in that. Yes.
We have a question from Lorenzo. Yeah.
Yeah. Thank you for the nice presentation. Two questions, one for Martin, one from Yassi. So. Martin, in this very nice conducted, emulated target trial, so we know that complex intervention like ECMO comes with lots of unwanted side effects. So does the emulated trial take that into account, or is somewhat underestimating in your analysis?
Thank you, Lorenzo. That's a very good question. And yes, we try to take all different type of factors into account that can influence the relationship or the association between exposure and outcome. However, registries often do not collect data that granular, and all observational studies have a certain risk of residual confounding, and there is a risk of model misspecification. And that's why I think it's so important that you do not just use one approach and one methodology to emulate the target trial. So if you use the cloning, censoring, weighting approach, you model the exposure. That's one way to do it, but you should then validate this with a model that is or with an approach that is modeling the outcome in order to see if the two approaches lead to the same or similar results. And then you do sensitivity analysis. So if you investigate treatment strategy that limits driving pressure, as an example, you investigate the reverse strategy. So you expose all patients to high driving pressure. You'll use control outcomes like initiation of renal replacement therapy as an example. And if you see that limiting driving pressure has a dramatic effect on the initiation of renal replacement therapy, although there might be some link, but at least it raises questions whether you just generated nonsense with your models. And that's, I think, the only way to approach the true estimate. And ultimately, observational studies and RCTs are complementary. So ideally, you emulate the trial and you validate it with an RCT. Or the other way around. You have an RCT, you have difficulties explaining the findings, so you benchmark, you use the RCT as a benchmark, you establish your models benchmarked on the RCT and then answer your research question. It's complementary, and it will accelerate research and drive us further and advance the field.
Thank you. Now I switch to my Italian soul, and that likes very much the helmet, you see. But so why it's been so difficult to have a large randomized trial showing the efficacy of the helmet over OptiFlow oxygen or over the other oxygen delivery treatment? Is that because the expert one, like in Italy, they lost equipoise, or there is something more about it? And following this, do you think in a potential RCT we should really have three arms, control, CPAP, and non-invasive ventilation, or can you editorialize a little bit more about the difference of CPAP and non-invasive on the helmet in a potential future trial? Thanks.
Great question. So I think for any clinical trial, interpretation of the results have to take the context. So our trial was done during the heat of COVID-19 pandemic. And we said, we're using helmets, so it might be a good idea it is a good idea to test whether it's effective or not. But it meant that we are doing the trial in sites that have not had a lot of experience with helmet, okay? So one interpretation of the results is that during a pandemic of COVID-19, when you implement this in sites, some of them have experience, some of them have experience. Helmet was as good as mask and IV, which is actually good. If I repeat this trial after having experience with hundreds and hundreds, if I repeat this trial in Italy, probably the results could be more positive towards helmet. So I think the context is so important. So you probably are in a better position why the Italians don't want to do a randomized control trial, because they love helmet, I think. And they use it through the equipoise for helmet. In sites that use helmet is towards helmet. In the sites that don't use helmet, they are worried about, I mean, there's a cost and there is inconvenience, and so there are other factors that it's easier to just put a face mask. But I think the trial is needed, and I agree that we need also to compare the non-invasive mode versus CPAP versus other things. I fully agree.
We'll take one more question from the audience.
Briefly, that's an opportunity to do an emulated trial as well, as example, and measure effectiveness of helmet versus other strategies under real-world condition, see whether there is heterogeneity of treatment effects, identify which population might benefit the most, and then do the confirmatory trial.
Go ahead, yes.
I don't want to delay you further from lunch. My question is for Professor Yassin, right here.
Yes.
And it's related to, you mentioned that lung volumes are unreliable when the patient is on helmet non-invasive ventilation, correct? The tidal volumes on the monitor.
They are volumes, they are not tidal volumes.
Or volumes.
So, yeah,
right.
the volumes you're seeing on the monitor or ventilator are not lung volumes. They are the air that's going to the helmet.
So that said, how can you count?
You don't measure it, you don't look at it.
So how can you account for transpulmonary pressures and tidal volume swings to prevent further lung injury in these patients?
Very good question. So I think you cannot rely on these volumes at all. And how to measure volumes in this type of treatment is very complicated. So I think we need to learn a lot more about the self-inflicted lung injury in non-invasive ventilation in general. I mean, helmet or mask and IV, similarly. We learned some for the invasively ventilated patient, but I think this research in non-invasive ventilation is harder. Helmet is similar to mask and IV. It's a very important question. So if we want to know the minute ventilation, you have to do blood gas. I mean, simply, you have to look at the CO2 trends. But the air, the amount of air is going to the ventilator, reflect how much air is going in and out this bag. So completely not clinically relevant.
It's actually hard to find good data demonstrating that sustained interventions on transpulmonary pressures are associated with outcome, even in mechanically ventilated patients. So it highlights that there is opportunities for lots of further research there, and we need to learn more about that.
All three, one final comment from all of us. In the post-inspiratory loading paper that I showed by Gallagher and colleagues, they looked at the inspiratory loading, so patients that just had high dynamic transpulmonary pressure, like basically high assessed, and they actually found no impact on the diaphragm. So when we talk about lung and diaphragm protection, we think excessive efforts are bad, but even in their own data, they didn't see the same signal with the neuromuscular coupling over time in patients with just high inspiratory loading. So we still need a lot more data to determine what we should do. Yep.
If there are no more questions, we'll end the session here. Thank you very much for the speakers, and thanks for the audience. There is an announcement.
Break for lunch break.